So thank you very much for the chance to come and share with you a community perspective around implementation science. I think I'd first like to ask how many community partners are with us today. I see a lot of colleagues from across the university, but I want to know who our community partners, if any, that we have here. Great. We have a spattering of community partners, so I look forward to you keeping me straight on this here. So what I'd like to share is some research and community issues that impact implementation research in a community context. The exemplar that I'm going to be sharing with you is my experience both in developing and disseminating an evidence-based intervention directed at reducing sexual risk behavior for youth, and then some comments about moving forward the field. So we had a definition of implementation research previously, and this one is somewhat similar to the other one. But what I would like to highlight as a way to remind us or to ground us is that when we talk about implementation research, we're not only talking about health systems. Health and health care happen in communities, and for us to be cognizant of that as we move forward is an important step. Certainly there are a lot of similarities in what Jeremy presented in terms of challenges and issues that are happening in healthcare settings that resonate in the community. And I think perhaps a shared assumption that we have both in community, as we think about knowledge transfer in health systems and communities, is that we might share this same flawed assumption. Where did the field get the idea that evidence of an intervention's efficacy from carefully controlled trials could be generalized as best practice for widely varied populations and situations? So importantly, there are gaps when we talk about knowledge transfer, adaptation of evidence-based programs into the community. And so when we think about research and development of interventions, we usually develop interventions that are very time and resource intensive. We focus on the maximum intensity. Working with a colleague of mine who's developing an intervention in a community setting, and as we were peer reviewing her proposal, the comment from my colleagues was, people are spending more time in this intervention than they spend in church. So the likelihood that this is going to transfer in real life setting is a problem from the front end. There's usually limited generalizability in the proposals in the interventions that we develop. We usually look at them being site-specific, patient-specific, population-specific, and context-specific. And importantly, there's limited flexibility in the interventions, and we expect a high degree of fidelity in terms of delivering them. When we look at transferring these interventions into communities, we're looking at doing these in areas where there are limited resources, where people are looking at, I need to do just the minimal to get by because there are other demands in that particular context. They work in settings, or this intervention is being implemented in settings where there is a need to include many patients, many different types of populations in diverse settings. And importantly, they need to learn and understand and want to know how to adapt and also have some flexibility in how the intervention is being delivered. Just one push-pull from the field is that there's a big push in terms of developing culturally specific interventions. Mine was a culturally specific interventions, but that certainly has created issues in terms of communities wanting to develop and use the intervention not for just Latino adolescents, but also for other adolescents in their community. So I'm going backwards here. So the tension also relates is because we have a certain model in terms of how we translate our models, or interventions, which rely heavily on academics. That in the terms of the development of the interventions, we have variability in terms of how communities are involved, how communities feel and own the actual innovation that it is that we're developing. And many times as we're developing these interventions, there's limited considerations of the community priorities, assets, and challenges. We rely in translation about tiers of evidence. It's like, what is the best evidence of efficacy that we have that we can move these interventions into practice? And we're usually limited into a single focus intervention. Let's look at sexual risk behavior. Let's take a look at tobacco cessation. But there's when we're looking and developing these intervention, there's very little intersection. And that's just not the real world. When we take a look at community models in terms of translation, many of these are community-driven. There's a lot of work in terms of community-based, participatory-based research where we rely on and look on building community capacity to identify issues, to take a look at solutions, and we rely on community expertise. But many of the movements have limited consideration of how evidence-based interventions should be worked in terms of these issues. So we have a ready-made solution for a problem that they haven't identified yet. One of my colleagues refers to evidence as tiers of, in the community, Kurt Organista, as tiers of evidence, meaning that they're blocked from developing and implementing solutions that they have identified as being reasonable or having any chance of working because they don't have the evidence necessary to convince funders or other agencies that this is an approach that they can use. And importantly, they're looking for a comprehensive focus. Give me a program that's going to deal with multiple issues, not just one. And so this is a comment from a paper that talks about, that illustrates the tension. And so we feel very limited in terms of their choice and adaptation of evidence-based interventions. There's just a clash of, it's like a culture clash to me around the culture of research and the culture of the street and the reality of these people's lives. It doesn't fit. This health impact pyramid, I think, which many of you seen from the director of the CDC, Frieden, presented this health impact pyramid. Most of our interventions and our work are at the top part of the pyramid, looking at counseling and education and also clinical interventions. But when you move these interventions to community settings, what they're primarily faced with is how is it that we deal with the socioeconomic factors that influence the lives, that influences the context, that influences some of these behaviors here? How is it that we can work on changing the context to make healthy behaviors the default decision as opposed to a risk decision? And certainly we know that dealing with these more distal factors are going to have a longer and stronger population impact, but what we're really focused on in much of our work is the increasing individual effort. So it's not like any of these are sufficient by themselves, but I think understanding the context of what the work we're doing and how that fits in is an important consideration. So I'm going to talk about my work and the intervention that I developed from 2 randomized controlled trials, one in Philadelphia when I was at the University of Pennsylvania, and also in Monterrey, Mexico, that focused on, actually the intervention was an adaptation of asexual risk reduction that we tailored specifically for Latino and Mexican youth. It's a 6-session small group format. In our randomized controlled trials, we had great long-term outcomes that demonstrated adolescents had increased condom use, decreased sexual intercourse, and a decreased number of partners. And in the development and testing of the intervention, we certainly had community engagement, again, a community-informed approach, where our community participants acted as facilitators. They provided us feedback in terms of the development of the intervention, bought off on the format, worked with us in terms of recruiting our adolescents, and provided us feedback through the way. The dissemination process that I've been involved in this efficacious intervention has been through the CDC and the Division of HIV and AIDS Research to Practice model. They have 3 components of this model. The first is the prevention synthesis group, where they take a look at identifying interventions that have been developed that focus on HIV prevention or factors that contribute to risk behavior, and classify them in terms of those that are ready to go on into the field. And mine was classified as one of having best evidence. And the other components I'll talk about shortly, the replicating effective programs and the diffusion of effective behavioral interventions. I'm also going to talk about this in the context of not a theory, but a framework that helps understand some of the complexity as we're talking about dissemination and implementation. And this was developed by Wandersman and colleagues, who talks about 3 separate but interacting components: prevention synthesis and translation, support system, and delivery system. So within the prevention, synthesis, and translation system, this involves activities to prepare innovations discovered in research for use in real-world settings. And an important component of this, similar to what Jeremy talked about, is to identify not only the outcomes, but what is it? What are the critical features that are associated with the intervention that make it effective? So most of the work that I did here was funded through the Replicating Effective Programs of CDC. It was started in 1996, and their whole purpose was to convert these efficacious interventions into how-to materials that could be used by local agencies. And what they emphasized, or wanted to emphasize, was fidelity to the original protocol. They understood that just putting out a list of interventions and saying, here's the package and how to use it, was not sufficient, because communities would get the interventions and say, we really want this, we want to be funded to do this, but you know what, I'm going to add this component, I'm going to take away this component, I know this was used for this, but I'm going to use it for that. So by the time they finish with the program, it has something that doesn't resemble the original intervention. So emphasizing fidelity to the original protocol. As part of this process, we had to develop a set of materials that would assist in the implementation by communities. Obviously, the facilitator's curriculum I had, but we needed to develop an implementation manual that presented the program, gave it an overview, presented the science, what it was and what it meant, identified what the core elements, provided information for communities to understand, again, the whole context of decision, understanding what was needed from pre-implementation to sustainability. We provided information around cost, around staffing needs, around recruitment, provided additional resources that might be useful for them, and provided a logic model, which is useful for them in securing future funding. And then we also had to develop a training of facilitators manual that was not only context specific to the curriculum, but what were the additional information that facilitators might need to know in order to implement that curriculum together. So an important component of what we had to do during this process was to identify the core elements, and these were the 6 that we came up with. These came from both, again, some of the analysis that we did, the mediation analysis we did to understand what components of our theory were important and made a difference, and you'll see that in number 3, looking at activities that increase knowledge and influence positive attitudes, belief, and self-efficacy regarding sexual risk reduction behaviors. Much of this information that on the other core elements come both from the process feedback that we had, as well as feedback we had from facilitators and my experience in both facilitating groups and interacting with the facilitators and being part of a very active part of the testing component. So these are core elements, and these are the elements that we tell communities, these are things that you should not change. These are the things that are important to have fidelity to, because if you don't, we can't assure you that you're going to have the same outcomes that we had in our randomized trial. But we also provide communities with flexibility and say these are things that you have flexibility that you can change and should think about. So for example, we delivered the curriculum, 6 60-minute modules that were developed over 2 days. And we said if you want to develop them and have them 1 hour module, 1 day a week, want to do it in 2-hour blocks. We had to work with one school because they only had 45-minute blocks that they could do, so we had to work around the curriculum. That's what you have flexibility with. We also have flexibility, for example, if you want to do all male groups or all female groups. But we give them parameters and things that we think that they can change that shouldn't make a difference in terms of the intervention efficacy. As part of the process, then, we pilot tested our materials, our training, and did observations of 3 different case agency sites that were interested in carrying out the curriculum. So what we found was that agencies were able to carry out the program with fidelity based on the training and the materials, that the adolescents and facilitators liked the program, which was an important, and we got some both affirmation and some suggestions on how to revise our training and other supporting materials.